copies to Michael if anyone would like a copy of it. I tried to make it as user-friendly. All of the pictures have what's called alternative text, so if you click on it, it should describe what you should be seeing. But I have our phone number and address for our clinic up here. If anyone thinks that a low vision examination might be helpful for them, feel free to connect with me after as well, and we can talk about how we could help you with that. So I thought I'd just start by first saying what is low vision. There are a lot of different definitions or what people understand low vision to be. I think in the most simplest of ways, low vision describes vision problems resulting in difficulty performing everyday activities. So low vision does not necessarily mean that you are legally blind, absolutely blind. I see patients all the time who maybe have perfect acuity, but are really affected by glare or have really poor contrast. And so I think that anytime your vision is preventing you from completing an activity that you used to do independently, could qualify you for having some low vision or having an exam with a clinic like ours. Typically, these types of vision problems cannot be fixed with glasses, contact lenses, or surgery, and it oftentimes affects your level of independence. So there are a few different ways I think about how vision can be affected, and each of these ways has different symptoms that might present. But I will just take this time to also say there could be a room full of people that all have macular degeneration, for example, and probably no two people are going to have the exact same symptoms. The way it affects your eye, what activities you're performing on a day-to-day, it can all be so different. And so that's why it's a really unique, individualized approach that we try to take. So the first thing is central vision loss, whether that's having just blurry central vision, having blind spots in your central vision, peripheral vision loss, so more of the outside peripheral part of your vision. Typically, we think of things like glaucoma that can affect your peripheral vision. Tunnel vision is kind of an extreme version of that. Impaired contrast. Contrast sensitivity, if you think about if you're trying to read a newspaper and the font is not quite dark against the background, maybe they're blending a little bit more together, or you're going down a curb or stepping off of a sidewalk, and the contrast between the color of the sidewalk and the road are not that different, and you have a hard time judging the depth and seeing it. That's contrast, and there are certain conditions that affect that. And then also impaired color vision. We see a lot of drivers at Ohio State's College of Optometry, and so some people come in with visual problems related to their inability to distinguish two colors from each other. So just to give some photo examples, so the top photo I have here shows a mountain scene, the very top one having normal vision, then central blurred vision. Scotoma is a fancy word for a blind spot. Most people think when they hear scotomas that it must be this black spot in the center of your vision that you can't see around. But not everyone's scotoma is like that. Some of them it could look like a haze or a fog you're looking through. Other could just look patchy, distorted. And that's another word, metamorphopsia means distorted. So some people that have conditions that affect the macula, like macular degeneration, when they look at a wall, it might not be a straight line. There might be bends, waves, parts may be missing. That can be something called metamorphopsia. The bottom left-hand photo is an example of someone who has peripheral vision loss. So you can see they're looking out onto a city and they can only see the very central portion. And then over here is an example of what contrast looks like. So the top is a beach scene, the bottom is a city scene. And so from left to right is increasing levels of contrast. So things might look just more washed out, more gray for people who have conditions that affect the level of contrast. So I thought I'd start by just talking about some common causes of vision loss. We work a lot with patients or clients who oftentimes their disease is managed by an ophthalmologist or specialist, and then they come to us for more of the rehabilitative side. But oftentimes the complaint I hear is that, for example, a retina specialist, they might only be with you for 5 minutes injecting the medicine in your eye and then they're off to the next person. So there's not always a lot of time to ask questions, to understand truly what's going on and what the goal of the treatment is. So I don't know everyone's medical history, but if there are questions, I thought this could be a time to maybe go into a little bit more detail. So that way if people don't have a grasp of maybe the condition they have, we can talk more about that. So one of the most common conditions is something called macular degeneration. More commonly in older individuals, the macula is the center part of your vision. So it's kind of the highest sensitivity, allowing us to have the best acuity. And in these photos, the black arrows are pointing to the area of the macula. The leading cause of vision loss over 60, there's two types, wet and dry. Typically with macular degeneration, if you have what's called the dry version, you get deposits that build up in your macula. When we're younger, the retina is able to take these cells that are older and need to be replenished or get rid of them. They're able to take it into the blood and get rid of it. But then when you have macular degeneration, the process of getting rid of these protein deposits, which are called drusen, it cannot happen as well. So they kind of build up and they affect the vision. When you have dry macular degeneration, over time, if these drusen build up, they affect blood flow, you can get death to the tissue around it, and that causes impaired vision centrally typically that can expand over time. The wet version is when the atrophy starts and the tissue is starving for more oxygen, these new blood vessels start to grow. But it's not great because these new blood vessels are not supposed to be there, they're not very strong, and fluid can leak out of them. So when you have wet macular degeneration, that's often when the ophthalmologist will inject what's called anti-VEGF. So Avastin, Eylea are common names you could or could have not heard of. And that tries to reduce these new blood vessels from growing, so that way you're not going to have the leakage there. Some people never convert to wet macular degeneration and just have dry the entire time. But typically, once you do get diagnosed with macular degeneration, you can never cure it. So oftentimes, if you are getting injections, the ophthalmologist will just be trying to figure out how long can you go in between injections so that you're kind of keeping a stable vision. So some people, that's every 3 months. It just really depends on the unique individual and how you respond to the medication. There are a lot of different risk factors for macular degeneration. We already talked about age. Things that you can't change, non-modifiable risk factors, typically more common in Caucasian individuals. There is a genetic component, so family history, and then all other types of genetic variants that can play a role. But you can see there are a lot of modifiable risk factors. The number one modifiable risk factor is smoking. Typically, we always counsel our patients that smoking is not great, especially for the eye. Also, secondhand smoke can play a role in this as well. Chronic sunlight exposure. Oftentimes, when we're trying to counsel our patients who have very mild macular degeneration, trying to increase the amount of antioxidants you're eating a diet that has dark leafy green vegetables like kale, working on overall health because it's all affecting the blood flow in the eye. So better cardiovascular health, controlling diabetes and hypertension, high blood pressure, those are all ways that we can try to mitigate the risks of our macular degeneration progressing. I already talked a little bit about some of the treatment with the injections, which is the photo to the right, and it's an example of what those medications look like. This middle one is called Syfovre. It's a newer one that's on the market. It's aimed for the people who don't have the wet, have the dry version, but have geographic atrophy or death to the tissue of the macula. This is a newer injection that's aim is to slow down the progression of how large of an area of tissue death you have. It's pretty new though, so there are seeing some positive results from that, but that would just be something that you would consult with your doctor to determine if you were a candidate for. The one all the way to the left is something that many of you may have seen or heard of, which is Asst vitamins. They are a vitamin that oftentimes we may prescribe to our patients who have more moderate stage macular degeneration, and we're trying to slow down the progression. Some people will ask if they should be on these preventatively or if they have the mild form, but studies have not shown that it slows down the progression in those mild forms or prohibits you from getting macular degeneration. And because these are kind of expensive or can be, and they're lifelong, usually supplements, we don't overprescribe to people who the literature has not shown that it helps. The next one I wanted to talk about is glaucoma. Glaucoma is a progressive damage to the optic nerve. The optic nerve, I kind of consider or describe it as it's like the cord plugging your television into the wall. It plugs in, it goes from your eye to the brain, takes all of the signals from your retina so that way you can see a picture. For people that have glaucoma, it's often caused by elevated intraocular pressure. So the pressure in your eye is building up high, causing damage to the optic nerve. We usually treat that with topical eye drops. In more progressive or serious cases, surgery might be indicated. Cataracts, another thing that if you live long enough, you will develop cataracts. Everyone develops them at a different speed. Cataracts are when we have a lens that's in our eye that focuses light onto the retina. And as we age, we spend more time outside, kind of like if you leave a newspaper outside on your front porch, it gets yellow over time. The same thing happens with the lens of the eye. So it's very natural age related. In developing countries, it's the number one cause of vision loss because they just don't have the surgeons out there to help treat it. But it is a very easy treatable condition, typically a surgery that is 10 minutes or less per eye. So we are actually replacing the lens. But it's not uncommon if a patient can't get approved for surgery or say that they don't want to get the surgery or it's leading up to getting insurance to cover it. It can cause negative effects such as increased glare. It can make driving difficult for a lot of people because headlights when you're driving at night. So we do see people while they're getting ready to get the surgery or have not gotten it yet that have problems. Yeah.
I had cataract surgery this year, and I thought, I think erroneously, that it would improve your vision, but it only improved the clarity, so that you're more susceptible to glare and you see colors slightly more vividly.
Mm-hmm. Sure, yeah. So in case anyone didn't hear, the question was about cataract surgery improving vision versus just making what you already are seeing clearer, brighter colors. So it can be twofold. So some people, if the cataracts get so progressively poor, we see their acuity worsen when we measure the acuity on a chart. So depending on how progressed they are, but it doesn't prevent if you have anything going on underneath of the cataract, like macular degeneration, any of those things, it won't necessarily improve the vision that way. If glare is the only symptom that you're having, it would definitely improve that, but not necessarily the quality of the vision. The other thing that people don't always realize too is that after cataract surgery, it really affects your ability to see up close. So if you were not wearing glasses before, you'll likely need reading glasses. A lot of times too, people think they'll get the cataract surgery and not need glasses. But if there's any resultant prescription left over, insurance companies are the bane of our existence. They're so fickle. So if you have astigmatism prior, a lot of times insurances won't cover the higher end lens replacement. So then you're still stuck wearing glasses. So it really depends on each case. And I guess if there's anything on top of the cataracts as well. Mm-hmm. Yeah.
I had a cornea transplant.
We're recording this, and your colleagues around here would like to see this when they are here.
Okay. I had a cornea transplant several years back, and it's going bad now. And when I close my good eye, everything's blurry.
Mm-hmm.
I haven't been to an eye doctor yet.
I'm really sorry to hear that you're going through that first. Yeah, with corneal transplants, there is always a risk of rejection of the transplant because it is coming from, I mean, a lot of times it recognizes itself as the type of tissue that your body produces. But if there is issues with rejection, that's something that the ophthalmologist would want to see you for definitely to determine, do they need to perform another one? Is there medication they can give you to help clear things up if there's swelling, which can sometimes come after that? So,
Well, it just started this week, and it's, like this. It's all blurry then when I close my good eye.
Well, and do you have someone that you usually get seen by that did the surgery in the area?
No.
Well, we can connect after too, and I can give you some recommendations or help you connect if you need.
Mm-hmm.
Yeah.
Thank you. please, if you do have a question, raise your hand so I get the microphone to you, because people have told me that they really appreciate the opportunity to see these talks when they haven't been able to be here. And if half the sound is not on the film because they were speaking without a microphone, it makes it a little less effective. So I appreciate it. When you want, please ask all the questions you can, but raise your hand so I can get the microphone to you.
All right. Ooh, we have a few more questions. Perfect.
That's a little bit.
Can you talk about the research on the retina? I have holes, a lot of holes in my retina. And of course I've lost my central vision, but are they coming to the point where you can get the retina replaced?
I wish. Yeah, unfortunately, no, not yet. They are working a lot with the retinal cells, but more in animal models right now. So a lot of mice or those types of things, especially because there are a lot of individuals with genetic conditions that affect the retina. So unfortunately, no retinal transplants. At one point in time, there was a new device that came out called the Argus implant, which was an implant they implanted into the retina to give your mind, it would kind of connect the brain so you could get maybe a rough outline of what was going on, even if it was not a clear image. But I think that got taken off of the market due to a lot of negative side effects.
Thank you.
Of course. Yeah. I think we have a few more questions in the back.
Good.
I have the cataract lenses also, and I've been told that I needed to have them, the one laser.
Uh-huh.
Could you explain that?
Absolutely. So when you have a cataract surgery, they put it's made of plastic lens in the eye. When the original implant is removed, they actually almost like emulsify your lens so they can like suck it out with suction. I'm sorry if that's graphic. But what happens is sometimes a few of those cells from the original lens of your body are kind of floating around in there. It's impossible. They're so microscopic to get rid of all of them. So it may be called a secondary cataract that can occur where a film grows over the implant. It's very common, happens to a lot of people. Typically, after that happens, it can affect your vision, and you're like, hey, I thought I was supposed to see clear. What they'll do is they'll bring you back into the ophthalmologist's office, and instead of having another surgery, they put you behind the microscope where you put your chin in the chin rest. They put a numbing drop in, and they use a laser to clean up the implant that's already there. Typically, once that is done, you don't need that again. And it usually takes less than a minute to kind of clear up the center part of that. So we usually say we're kind of cleaning up the implant that they put in.
So do you go back to the surgeon that did? You go.
Typically, yes. As long as you were happy with the original outcome and you like your surgeon, usually they're the best person that would clean up that implant for you.
Thank you.
You're welcome.
Yeah, I had cataract surgery a number of years ago, and I did have that second laser. But I still have a problem with bright lights when I'm driving at night.
Yeah, it's a little bit twofold because unfortunately, a number of years ago, they started making all of the headlights with LED that are so bright. And then when we're in the night or it's dark, our pupils start to get a little bit larger, so they let more light in. When you I see you're not wearing glasses now. Do you wear glasses ever?
I wear them for reading.
For reading?
For reading.
So usually when I talk to my patients, depending on their case, if they don't wear glasses while they're driving, sometimes I recommend them getting a pair of glasses that have an anti-glare coating or even a blue blocking coating, because it kind of just neutralizes and makes everything a little bit less bright without reducing the amount of light you're getting. I have some individuals who wear like a yellow tinted pair of glasses at night because it doesn't make things look darker, but it can cut some of the glare. So typically when that is the complaint, those are a few of the ways we try to reduce the glare.
I also have the beginnings of macular degeneration.
Okay.
Does that make a difference with the glare?
Not as much typically. I don't hear from my patients with macular degeneration, but it is, with the plastic lenses, they let so much more light in. Diabetic retinopathy is another common condition that we see patients have permanent or irreversible vision loss from. So when you have uncontrolled systemic diabetes, the blood vessels in the eyes become leaky and fat and blood can leak out into the eye, and that can cause swelling in the macula, so it can reduce your vision. Oftentimes, the treatment for diabetic retinopathy can involve having to do laser to the peripheral retina. We're trying to actually kill off some of the tissue so your retina requires less oxygen, so then new blood vessels won't be growing. People who have uncontrolled diabetic retinopathy are at higher risk for retinal detachment. If it's uncontrolled because new tissue is growing, it contracts, it pulls on the retina. With diabetic retinopathy, there's no really one type of way the vision is affected. So the photo I have down here is just to show, depending on where the blood is located, the leaking fluid, it can cause various different size blind spots throughout the eye, as well as just an overall reduction in vision. Treatment, so you can also, the same type of injection they give people with wet macular degeneration can help with the fluid accumulation in diabetic retinopathy. The top photo where you can see all the white spots that are around the retina there, that's what a fresh laser looks like to kind of mitigate how much oxygen the retina is requiring. Prevention tips, very similar to what we talked about for macular degeneration, trying to control the systemic disease. More difficult in those that maybe have been lifelong type 1 diabetic, because over time, the longer you have the condition, the harder it becomes to manage effectively, or the more likely you are to have the retinal findings. So, yeah.
I was diagnosed with diabetes about 9 months ago, and one of the things I was surprised at was when my blood sugar goes up,
Mm-hmm.
it seems to affect my eyes. I don't know if that's a normal thing, whether I should expect something like that, but it causes problems in the mornings. I try not to drive very much. After I've had breakfast, my blood pressure goes up. It goes up every meal of the day. So I have to time my driving with
Mm-hmm.
the conditions that I think my eyes will be in, and try not to be a nuisance on the roads.
That is not an uncommon symptom. So, especially in the beginning stages, while your doctor might be trying to figure out what medicine is going to work the best for you to keep you level, anytime the sugar is fluctuating, it affects the lens of the eye, which we were talking about with cataracts, for example. So, anytime the blood sugar is raising or lowering, more or less water can be drawn into the lens, causing it to temporarily swell, and that actually affects the clarity of your vision. So it's not uncommon as an optometrist, if we see a patient who has visual fluctuations, newly diagnosed, we might say, let's try and get the blood sugar under control before we change your glasses, because 5 months from now it could be different again. So it's not uncommon. So hopefully, as it becomes more tightly controlled, you'll experience less of that.
You also mentioned the oxygen content in the eye.
Mm-hmm.
I suspect that it's healthier to have more oxygen in the eye.
Yeah, so anytime the retina is starved of oxygen or it's decreased, that's when the retina can be affected, the tissue can die. So there's nothing necessarily you need to do to get more oxygen, but just controlling cardiovascular health can ensure that the blood flow is occurring naturally.
I have a sleep apnea,
Mm-hmm.
and I can't use a CPAP machine because I also have asthma. So what they did was give me an oxygen machine that does not have the pressure content that a CPAP machine has, but I use that, and I wonder if that does put more oxygen into my bloodstream.
Yeah.
Is something like that helpful for my eyes?
That does sound helpful. So we do know that people with sleep apnea that are not treated are at risk for things like glaucoma, because as your oxygen flow is fluctuating, especially at night, if there are moments you're going with less oxygen, it can change how much perfusion or blood flow you're getting to the optic nerve. So it is good that they have you on this alternative way to get oxygen. Um, Now, typically something like that would have to be over a long course of many years to see it affect the eye in a poor manner. But typically, yes. So if we see a patient, we suspect glaucoma and their optic nerve might already be more fragile. If we think there's any risk of sleep apnea, we'll recommend usually getting that workup done.
Thank you.
You're welcome.
I have a few questions.
Of course.
My first question would be the Asst 2 vitamins. I have spent a boatload of money on those, and they obviously didn't do anything, but then you're afraid to start using them. Because maybe something will happen then. At what point are they not effective in any way?
Sure. So I think if you look at the studies, they're oftentimes not shown to necessarily have the biggest impact if you've already converted to wet macular degeneration. It's typically that drug that they inject your eye with that would be the most helpful. And if you have very mild macular degeneration, there's no studies that have shown it slows down progression. So it's really in the middle where you're more moderate but at risk for developing wet. So for example, and I mean, it depends case by case. My grandmother has macular degeneration, wet macular degeneration, and her retina specialist said, you can really stop using these because you're at the point now where we're injecting you every 6 weeks. The eye vitamins are not as impactful. They're definitely never going to hurt your eyes. So I think that's why a lot of ophthalmologists don't say you can stop using them. I would recommend bringing it up to your ophthalmologist for your unique case to see what they say. But really, it's the early and advanced stages that they show are not as impactful.
What if you have one of each?
Half the dose. No, I'm just kidding. So if you have wet in one eye and dry in the other, that's probably why they wouldn't have told you to discontinue them, because you're hoping that the dry stage doesn't convert to the wet. Now, there are more advanced versions of the dry where you have geographic atrophy, they call it. Usually once you're at that point, that tissue is already lost. New blood vessels can't grow in an area where the tissue is already lost. So with advanced dry, with the geographic atrophy, you're not going to necessarily convert to wet because the tissue's dead. And so that might be a case where they say, hey, the AREDs aren't going to help with this eye. But if you're still kind of in that moderate stage where you have healthy, viable tissue, they probably would tell you to keep taking them.
You just saved me $20 a month. My other question is, what you have up there, what does low vision exam entail?
Mm-hmm.
And when you say low vision rehabilitation, what does that mean?
Sure. So that's typically kind of the umbrella that we talk about, because as a low vision optometrist, I don't just work with myself. So there are a lot of, we call it like the rehabilitation team normally, because there are other specialists, and I'll go over this a little bit further too. We're kind of, I feel like within optometry and eye care, the only specialty or subgroup within that our patients come in and tell us what their goal is. And we're trying to use, whether they're optical devices, non-optical devices, assistive aids, changing up ways that you do things to help people get back to their independence and successfully do things. And so it's more of a rehabilitation, because it might involve OT, a low vision therapist, orientation and mobility specialist. So there's kind of a group effort that I think is not the typical for the optometric field especially. So the next part that I'm going to go into talks a little bit about what exam elements are different than what you're used to at the eye doctor. So we typically, we will still check the vision, but if you've ever been to a retina specialist or an optometrist, they might kind of rush you through and how far can you read on this chart? We have many different types of charts that we use to help better quantify someone's vision. So we might have a chart that can come a little bit closer that you can see more of, that helps us better quantify. We also will check your contrast. So this picture I have up here, if you can see, there are letters that get more and more faint against a white background. We will oftentimes check that, which measures your contrast sensitivity, because that impacts how well you're able to do a lot of your activities and there are different methods to try and enhance contrast. If anyone has had a visual field test, that's what this picture is in the bottom. We have automated machines that can help us map out blind spots, but also map out your peripheral vision. So especially at OSU, we do a lot of this because we do a lot of driving recertification for individuals, or certain individuals that have vision loss that use telescopes for driving. We are also ones that evaluate them for those. We'll check glasses prescriptions. Oftentimes, if patients are having a hard time with reading, for example, and they were in a no-line bifocal or a bifocal, we might explore other options as far as just strong, high-powered reading glasses. So we'll try and figure out what style of glasses works best for you. And then we have other tests. Typically, we're not dilating our patients. We're really just coming in, focusing on what goals our patients want to be able to accomplish. So just to give you some example of things that we hear all the time that our patients have goals to be able to improve, I would say number one would probably be reading, but we try to spend more time with our patients. Our exams are often up to 3 hours long, potentially. It really just depends on what goals our patients have. So usually it starts with a big conversation about, if you say, I have a hard time reading, we'll get to the nitty gritty of it. Is it what we call prolonged reading, like reading a book, the Bible, the newspaper? Is it spot reading? You just want to be able to see your medicine bottle. You want to be able to read a recipe, something that doesn't require long-term reading. Driving is a goal we work with often, watching TV. People who don't feel safe walking because of their vision. I miss the curb. I bump into people on one side. We will talk about that. Recreational activities and hobbies are also a big thing we try to work with. So I just had a patient last week who likes to play bridge with a bridge club, but they can't see the cards. So we were working on different methods of, using large print playing cards, and what other assistive devices could we use? What type of lights could we use to help them be able to get back to something that they were no longer able to? Some other pictures I had a patient who is a big sewer and knitter, so we did a lot with that. Sometimes our patients come in and have no vision at all. And so we then turn to a lot of audio devices, whether it's talking books or things like that. So I tried to break them down because we talked a little bit about the goals, just to give you a little bit of insight into ways we help people. Every person is so unique and individualized that we kind of try to come up with a way that that person is going to work for them. So I know too, like, what type of house or apartment they live in. Okay, like this floor lamp isn't going to work because you don't have room for that. Or we really try to personalize it. So the first with reading are optical devices. So these mean has a lens. We're increasing the power of reading. So the first few steps might be a high-powered pair of reading glasses. Typically, when you go to a drugstore, if you're looking at reading glasses, they might only go up to a +3. There are times where we go up to +20, +30 for patients. Now, high-powered reading glasses aren't for everyone because you have to hold things much closer. But for people who want to be able to pick up a medicine bottle and require a lot of power, that might work for them in that instance. Handheld magnifiers, our patients will come in with a bag of handheld magnifiers they bought from the drugstore. Those lenses are not always the highest quality. They may not have a light built into it. So we'll try to do a more personalized approach in training on how to use a handheld magnifier. Loops, not quite as common anymore. Sometimes people who have telescopes to spot things for distance, we can turn into a telemicroscope, it's called, so it helps focus it for near. And then the other big one are handheld magnifiers or digital magnifiers. I would say this is more for patients who have contrast problems as well as need a lot of magnifications, but want to be able to see more than one word at a time. So there are both handheld and what we call desktop video magnifiers. So it uses a camera to then blow up an image on a much bigger screen. And as you can see in like this bottom right picture, it's black text on a yellow background. That is to help it just stand out and have more contrast. So some people have these portable video magnifiers in their purse or in their pocket. They can take them to the store. You can get a lot of magnification, but good optical quality. A lot of students might use this if they're in school because it can blow up their textbooks, or if they're taking a test. You can see these two on the side here. There's enough space where you could write underneath of it. Some of them can offer a camera that can pivot to magnify things at distance, up close, or even on yourself. So we call it like selfie mode. So if it magnifies on yourself, people might use it to help shave. They might help, put on makeup, things like that. Now, I will say these are the more high dollar products. So typically my thought is when I work with a patient, I try to figure out what is the most simple way to achieve the task without interrupting how you're used to doing things. And then if we figure out, as we go through, okay, a handheld magnifier is not going to work, then we go to the next step. So I don't just automatically go to the thing that's going to cost the most. I would say more and more commonly now too, individuals that have cell phones, tablets, iPads, laptops, if you already have a technical device, how can we turn that into something you could use to magnify things? So sometimes for people who like to read books but don't get enough magnification, using an iPad with the Kindle app or using a audiobook through Audible, through Spotify, through Libby is really nice because if you haven't heard of that, it connects you to your local library. So you can get digital books and audiobooks for free. Depending on your level of vision, you might qualify for the National Library Services talking books, where they actually send you a tape player and then can change out your tapes every month so you can listen to books that way. And some of our patients, we might say, oh, a high-powered pair of reading glasses could work if we just get in a large print book versus trying to focus on something that's 8-point font and so hard to read. So really trying to figure out what's going to be the best for each person. Moving on to distance, I will say that there are less devices for distance than for reading. Telescopes are our big thing. So telescopes usually you think of as almost like a half a pair of binoculars. Typically it's one eye, so a monocular. There are a few different categories, so whether they're handheld, whether they fit onto your glasses is usually determined by if you're just trying to spot something versus see something for a long period of time. So if I have someone that comes in that says, I can't read the street sign when I'm walking down the street or read what bus number is coming or see someone's face from across the room, they might hold up a telescope in front of their eye to give them a magnified view. The spectacle mounted are typically more for sustained. So if I have someone like this device down here in the left corner is called the Max TV. It works sometimes for patients who have vision of 2100 around there because it improves the vision by 2 times. So it clips onto your glasses, 2 times magnified view. The bottom right picture is to show, it's called a bioptic telescope, meaning it's mounted above the line of sight. And that's what individuals in the state of Ohio and other states can use for driving if they meet certain requirements. Head-mounted devices are kind of, I think, a newer, within the last 10 years or so, an ever-changing way of using augmented or virtual reality to help improve vision. So I listed some on here. These are just some of the brands: Iris Vision, TV Buddy, AceSight, and eSight. So the Iris Vision, which is the top, it uses a camera. It used to use a cell phone. Now it's a little bit different of a technology, but it uses the camera and it brings the screen that much closer to your eyes. Oftentimes these can be used for distance or near. This bottom is the Vision Buddy. So like things like the TV Buddy or Vision Buddy, sometimes you can connect them to your TV. So you could be sitting in the room with friends and it brings the image right in front of your eyes in this headset versus you having to see across the room. Again, expensive devices don't work for everyone. So I often recommend trying them out before we're going to move forward with it. But just to give you an idea of what's out there. And then this last part I want to talk about a little bit was some of the newer technology that you may or may not have heard of. So a big thing our patients are coming in to ask us about are the Ray-Ban Meta glasses. If you've heard or seen of those, there's a lot of commercials about them. So Ray-Ban partnered with Meta, and it's a pair of Ray-Ban glasses that have cameras on either side, and it uses AI technology. So what it does is uses the camera to capture what's in front of you, and it can read directly to you, or it can tell you what it's seen. So for example, if you have a menu at a restaurant in front of you, you could say, hey Meta, can you tell me what chicken dishes are available? And it won't just read back to you the whole menu, it'll actually pick out the information you're asking it for. They're not perfect, but they do a lot. I think they're also a little bit more affordable. We're talking a couple $100 versus a couple thousand, which some of the other head-mounted devices. You can also talk on the phone. It uses bone conductivity, so you're not actually wearing headphones. It uses where it touches around your ear. You can send text messages. So some of our patients that can't see their phone to use text messages, you can always use a lot of times Siri or Google if you have an Android phone, but the Meta glasses, you can receive text messages. It also can do translation of things. If you are on a trip and you're standing in front of a monument, you can ask it to tell you about it. So it's a lot of cool technology. Again, not perfect, but I think it's pretty promising. Tints and lighting are things that we try to incorporate at all stages because a lot of times for reading, the magnifier may not do enough. We might need to ensure what's the lighting like. So some different ways that we can control that. The first column over there are different pictures of tints. So oftentimes we might try fit over tints that go over top of a patient's glasses versus clip-on tints. We have oftentimes more variety of transmittance of how much light can get through in different colors that you may not have thought of or are available at the store. So it's not uncommon for us to take our patient outside and say, let's try on different colors and how dark they are to see what works best for you. And our patients might have a different color for when it's cloudy or rainy versus when it's bright outside. This is often too in our department where it's not always just about having poor vision. So I might see a patient who has chronic migraines that has really bad light sensitivity, and we still work with tints on them, so they're still seen within our service. The middle picture, we can sometimes incorporate tints for certain genetic conditions. So there's different conditions where tinted contacts might be best for them, can affect or help with glare. Using flashlights for certain people who have poor night vision when they're walking around to shine at the floor to be able to help see where they're going. And then these top two photos, I was trying to show an example of what we might call task lighting. So rather than just relying on the overhead light, with lighting, it's typically not the bigger the wattage, the brighter the light. While that might be true, the best way is the closer the light, the brighter it's going to seem. So task lighting would be bringing lighting to the specific task you're doing, not just relying on ambient or overhead lighting. Maxi Aids is a really great website, and I think I linked this. I have a whole packet of resources, both local and kind of things like this, which are websites or other more specific resources that have a lot of things for independence. So this is just an example of what the website looks like. So they have it kind of broken down between vision, other types of disabilities people might have, but then they try to show things like a large print Bible, something called a liquid indicator. If individuals come in and they say, I can't tell when my glass is full of water, it's a device you can put on the edge and it beeps when the water gets up to a certain level. A talking watch. We have writing guides, so if you can't see how to fill out your check, it kind of has cutouts, so that way it's a little bit easier to follow along. Large print bingo cards. So these are more non-optical related, so not using lenses, but they're ways that we can adapt the material you're working with or adapt your environment to try and help compensate. I will say this is not always my specialty. We have some of this in our clinic, but oftentimes we refer to other rehabilitation specialists who can work a little bit more with combining optical, non-optical, or what other non-opticals are indicated. Another resource I wanted to bring up, if you are a tech person at all, if you ever have browsed like YouTube videos, this is an individual, his name is Sam. He runs a YouTube channel called The Blind Life. So he has visual impairments, and what he does is he will oftentimes work with different or new low vision products and explain what he thinks about them, the pros and cons. Everyone's not going to feel the same, but I've had a lot of patients who appreciate his insight. It's a lot different hearing from someone who has visual impairment versus someone like myself who does not, that it's just trying their best to explain it. Or if they're thinking about investing in an expensive device, he might break down a few different types so they can get some insight that way. So I wanted to bring up some other low vision specialists that we work with besides the optometrist. So oftentimes the optometrist might be kind of the first person you see that's going to look at glasses and optical devices. But then we work with a lot of other different people. So some occupational therapists are might be dual certified and certified low vision specialists as well. So oftentimes I think we refer a lot with those people for training on devices, for non-optical devices, to kind of help. I might prescribe something, but how do we make it functional? Or determine, a lot of times I might prescribe something, they might come back to me and say, hey, this didn't really work for this reason. What do you think about trying this? And we can work together as a team. Orientation mobility specialists, individuals that help to train you how to navigate more safely and maybe independently. For some people, that might be with a white cane. Other people, it might not be. It might be to teach your loved one how to better navigate with you and help you as the visually impaired individual. Teacher of the visually impaired, those are individuals we work with, especially with kids or school age people who can make sure recommendations are being met and academics are being delivered in a way that is helpful. And social work is also a big part of our team to help connect to local and state resources. So some local resources I just wanted to bring up so you would be aware of. If you have I provided the digital copy of this, so if you end up getting the digital copy, these are all hyperlinked so you can easily access them. But then on the handouts in the back, I put the websites, but I also put QR codes. So if you have a cell phone, a smartphone, it'll take you by scanning the QR code as well. So Opportunity for Ohioans with Disabilities, that is an organization that is statewide. They have two branches. So they have vocational rehabilitation, and then they also have the independent living program. Vocational rehabilitation, they have counselors who, if you're still working or wanting to work, they can help make sure that your job is, you're getting different devices you might need for your job. Independent living is more of, you're retired, you're not working, but how can we make you more successful and independent? I will say, with the state of affairs right now, budget cuts are inevitable in some of these state programs. So I think the independent living program right now is kind of on a pause. They're taking new applicants, but I don't know that they're getting to new applicants just yet. So I wanted to put that disclaimer out there. The Ohio Department of Aging, so I think they work pretty well with those who have visual impairments, but also caretakers, just for other difficulties or problems you might be facing in aging. They have some resources there. Prevent Blindness Ohio, they do a lot of good educational programming. Pilot Dogs is a local Columbus organization that has seen eye dogs. So for some of our patients, that might be a process or part of their getting around more safely. And then Assistive Technology of Ohio is actually through Ohio State. So they have some loaner programs for assistive technology or some of the devices we talked about, or they at least have a room where you could go try out certain things. They don't have everything every single device out there, but they have a lot of good stuff. Another thing too is, when you are losing vision or have lost vision, it can be pretty isolating and it can be hard for other people to understand. You may feel like it's hard to get to places. You don't want to inconvenience your loved ones or your friends. So I always like to point out that there is a local support group. I think sometimes it's nice to also just be able to talk to people who are going through something similar and learn how they do things. So for this low vision support group, they meet one time a month. It's at the state library downtown, but you can meet virtually with them. So I put the individual's name. His name is Mike Pitroff. He's the one that runs this group on Meetup, which is a website. And this is what I have the screenshot of here. That's where you can also RSVP or request more info.
Yeah, let me just mention that we have had quite a bit of dealing with Michael Bishop. I'm too close to speakers here. And I get a mailing from him every month that I could forward to anybody who's interested, in which he lists all of the meetings they have. And we met in the first meeting we had with Dr. Wu some months ago.
Okay.
He's always ready to help.
Perfect. So that's all the structured slides and everything I have, but I'm happy to answer any more questions or expand upon anything we've talked about.
This is the patty show, right?
Is this working?
Yep.
Okay. I don't know whether this is a common situation with people or if I'm just a weirdo. But in the time I've been sitting here looking at that screen, or if I look at any screen for a period of time, my vision vision gets affected, I get a headache and I'm off balance.
I don't.
Screen time is difficult, no matter what the screen is.
Sure. I mean, without knowing too much of your personal history with your eyes, screens, I think definitely with glare, with just staring at the light, can be one part of what you might be experiencing. The other thing that's not uncommon for those individuals who spend a lot of screen time, whether that's phone, tablet, TV, when we're staring so intently, we tend to blink less. So our eyes dry out faster and more commonly, which can cause blurred vision, eye pain, fatigue, feeling pressure behind the eyes, headaches. So it can be a number of different things. So oftentimes what we try to do first is make sure that if you're staring at a computer or a phone or a tablet up close, that you're corrected with the right reading power. And then we think about things like the lighting, the glare, the dryness, and go from there. So it's pretty multifactorial, but it's not uncommon. You're not weird for that being what you're experiencing.
If someone wants to make an appointment at a
Mhm.
low vision clinic such as yours,
Mhm.
does their insurance cover that?
That's a great question. It depends. We typically are, I will say it's twofold. A majority of our patients are coming under their medical insurance because if you have impaired vision, there's likely a medical cause for it. So typically we can bill like a lot of Medicare, Medicaids, a lot of private plans as well. There are individuals who maybe they're retired teachers or retired state employees. VSP, which is Vision Source Plan, they have some plans have a low vision component that can cover up to $1,000 every 2 years in low vision. So it just depends. Um, I will say, thankfully, where I work, we have a little bit more flexibility because we're an educational institution. If someone's insurance does not cover it and they cannot afford it, that we have other alternatives we can sometimes work out. My plan too is they're printing up some new pamphlets and brochures for our clinic, not specifically to low vision necessarily, but our whole OSU clinic that has the low vision information. And I'm going to get those sent over here. So that way, for anyone interested too, they'll have that. But typically to schedule with us, a lot of times we would require a referral from your ophthalmologist, not for insurance purposes, but just to get records of what's going on. So usually that person will send over notes. But then once you're set up with us, you don't need continued referrals moving forward or anything like that. And it's not uncommon, like we might see someone a few times. There's a lot that people have goals to accomplish, and we might not always be able to get it done in one appointment, but that's no problem. We'll see people back as many times as we need.
So if I'm already seeing a retina specialist and they have an
Mhm.
eye center and my insurance covers that,
Mhm.
could then I progress to your
Mhm.
rehabilitation clinic?
Absolutely.
Thank you.
Yeah.
I don't know how many of us still drive cars. I try to keep driving mine. 2 years ago, we had to take an eye exam, DMV, and I almost failed. What saved me was I knew my eyes were dry, and I sat there for 2 hours before I finally got a chance to talk to one of the clerks.
Mm-hmm.
What happened was she was ready to fail me, and I said to her, I need to get some drops. My eyes are dry. And I asked her if I could let my daughter go out to the car, which is right outside the door, and get my eye drops. At first she said no. I said, ma'am, I waited 2 hours to see you. I don't want to go back we get to the end of the line and start all over again. So she said, okay, make it quick. So my daughter got it, and I came in and I passed the exam. I found out since then that you can get your eyes examined outside of the DMV.
Mm-hmm.
And if you can get it done in a place where they will certify the results, that the DMV saves that or will receive that or approve of it. The thing of it is, I don't like the machines that they have.
Mm-hmm.
And there's just something about it. I actually get holes in my vision, and it's extremely hard for me to use that machine.
Yeah, that's definitely not uncommon. We hear that a lot from our patients. So yes, technically any optometrist can sign off on the BMV form. I will say some optometrists may not feel comfortable or have as much experience filling that out. At our clinic, we see people all the time for driving exams, we call them. Now, I don't know that we can bill a driving exam through insurance, so oftentimes those people are paying out of pocket. But what we do is we will evaluate someone's vision, both the acuity and the peripheral vision, because those are the two requirements in Ohio. And we will print out the BMV form, fill out all the information, and email it to them electronically to their special unit that they have for vision. And then typically they'll give our patients a call within 48 hours to let them know we've received your information. It should be in their system. So then no matter what BMV you go to, they should be able to look that up and you shouldn't be required to take it there. Mm-hmm. Yeah, I will get you information for that.
I had a question about something that you put up there. It said red letter version of Bible. Would that be someone that is somewhat colorblind, or, you know, what if it's like it said red letter, it was just a real.
Yeah, so it really depends. So what this Bible is it's large print, but then some of the letters are red versus black. It really just depends on what eye condition the person has. There are certain genetic conditions where red helps someone see better. I will say for a majority of patients who don't have that specific condition, I will show them different types of contrast. So white on black, black letters on white, yellow letters on black, just to see their personal preference. A lot of times it's just a personal preference.
Thank you.
Of course.
And the next one is, I am wondering if you could put an actual percentage number on how much a large print publication differs from a normal size print book.
Oh, you're putting me on the spot here. That's a great question. And if you know the answer better than this, please just let me know. I think it depends on what type of publication. And there are certain, I've seen them from like large print, extra large print. I would say if you're looking at a typical large print, if something like the Bible is in like 10-point or 8-point font, it's going to go up to 14 or 16. So hopefully trying to double it in size. It really just depends on the material though. But every public library should have a section that's large print as well. Yeah.
So I was curious if, well,
Yeah.
this is large and this is not, how much of a variance is there? My eyes don't send me anything that I seem to say, oh, is that. It just seems like I needed some kind of a number.
Mm-hmm. Yeah, I would say a majority would probably be 1.5 to 2 times standard print. The other nice thing about some of the digital options, so there's one Bible app I commonly refer to my patients to use on the iPad where you can control the font size, but then you can also control the spacing between the lines. Because for some individuals, things start to blur together and this letters start to swim on the page. So sometimes when we can separate the lines a little bit more, it makes it a little bit easier for the brain to interpret.
Library books in large print are in 18 point.
Oh.
There are books though that come out that say larger.
Yes.
They are not in 18 point print.
Thank you.
Okay, well, my memory is going a little bit too. How often do we have to have the eye exam when we get our driver's license?
So if you're over the age of 65 in Ohio, it's every 4 years. Now, there are certain cases where, depending on, like I have some patient, your optometrist or your eye care provider or your medical provider can put you on something called a medical card, which is it's like a 2-part license. So if I have a patient who has really bad diabetic retinopathy and that can fluctuate so much from year to year, I might say, let's put you on a medical card, which means your license will say it doesn't expire for 4 years. But this secondary piece of paper you're going to carry with it says you have to come see me every year to make sure that nothing's changing and that you're still safe to drive. The nice thing about that, if I do put someone on that, is they don't have to go into the BMV every year. They just come see me every year and I send the BMV their results. They mail them that second part, that paper card. But typically, yes, I believe if you're over the age of 65, it's 4 years. Under the age of 65 now, they offer 8 years.
Another question is, I was trying to read the handout that we had at our dinner the other night, and I could not read the yellow, the things that were printed in yellow on a white background.
Yeah.
Is that a normal?
I think so, because there is, as we age, we do expect contrast sensitivity to decline. It's not going to stay perfect forever. And so something like yellow on a white background is not great contrast. It's not something like, so I usually, if someone needs a work accommodation or school accommodation, will say avoid pastels or light colors on white background. So that could just be a normal age-related thing, that it's just poor contrast trying to see it, not that your eyes have poor contrast sensitivity.
Would a magnifier help then, something like that?
In that situation, it might. It might be hard though, because it's not necessarily the size always that is the difficulty, but just discerning the background from it. So it might, but it might be something more where we say to whoever's printing the menu, like, let's not do that.
Because I've run into that on posters and different.
Yeah. And there are some ways you can control it, food labels, things like that.
Yeah.
Now, I will say there are some phone apps where it can use your phone camera to invert the colors. So if you have a cell phone with you already, then using that app might make things easier, because then if it flips it, it could make it look white on a black background instead.
Do you know what that, yeah.
Sure, there's a few different ones. So depending on if you have an iPhone or Android, iPhone, the one, I'm going to pull out mine so I don't get it wrong. The ones that I really like, there's one called Supervision Plus, and it's an actual plus sign. The icon looks like a magnifier, and that one is great. For Androids, WeZoom, it's called, is really good. Those are the two, I think. You can also do that on your accessibility settings on your iPhone. So, I mean, this is maybe a good segue too. What I had talked to Patty and Michael about too is, if there is interest in things like adapting cell phones to be more user-friendly for those with visual impairments or such, I'd be happy to come back and do maybe like a more hands-on workshop versus a lecture style, and maybe bring some of my students too, so we could help those individuals that have cell phones that wouldn't be able to use them a little bit better. So there's a lot that the phone can do if you have it. And it's kind of nice because in my mind, I think that it's less items to have to carry around and work with if you kind of have, everything works with one.
We're gonna do that, Chad.
Love it.
Yeah, pass it on. I'm gonna be rude now, I've got another medical appointment at 3, but if you can stay for a while longer.
Yeah.
And if Megan would like to stay and speak about how this touched you and how you might interact with some of the things we saw on here, I'd be happy to leave that in your good hands, and I'll head off and do my other thing. So I'd like to thank you. Can I stay a little longer?
Yeah, absolutely.
Okay, thank you so much.
Of course.
I'll pass this over to the boss. There's got a sign-up sheet for the vision group. If you're not in it already, please be sure to register, and also check the things in the back, and maybe I'll get to you in a couple of minutes. I'm off. Absolutely.
Yeah.
I have a teacher voice.
Okay.
Do you have neurological patients where the problem is a neurology one, and it's not the
Tried to do that.
eyeball, or
Mhm.
anything with the eyeball?
But you
Totally
did
out
work
of the
for you.
brain.
Yes.
I'll say it again.
I asked if he had neurological patients that the neurologist would be the person advising, and that the problems or the therapy would come from not the eyeball, but the problem comes from the brain, so it would have to, it's still vision,
Yeah.
definitely low vision.
Absolutely. So, I mean, I saw someone yesterday who has 20/20 vision, but from a stroke has missing parts of his visual field in each eye. So we definitely see people that the issue is more neurological, whether that is causing difficulties with peripheral vision or other. I would say between us, and we have a binocular vision department. So sometimes if we have someone who has like a traumatic brain injury or something more where it's the eye's tracking things or how the eyes are working with the brain, we kind of collaborate a lot between our two services.
Okay, my question is pretty much the same as yours, but when I have, if you've ever had a brain scan where they take you, put you in that thing and then,
Like an MRI or something like that?
Well, it's like you're driving a train and in the hospital on that. But the problem that I have is that when they come up with the X-ray reads that they put on it, instead of in the front, it's in the back. And I think it's dysplasia or something like that.
He has post-portal atrophy.
Okay.
Okay, that's what.
Mm-hmm.
That's the thing.
Yeah.
He was diagnosed with post-portal atrophy, and so it's perceptual, but also it's visual,
Mm-hmm.
and it's been deteriorating. And
Yeah, so that's probably, those types of conditions are more things we might collaborate with our friends in like the binocular vision and visual processing to work together to figure out, are there modifications to the visual stimuli we can make to make things easier to process and how the eyes are kind of working. So yes, that's something yeah.
do you know anything about kaleidoscope vision?
I don't know if I'm familiar with that one.
Things look pixelated, and it doesn't matter if you close one eye or the other, it's still everything in front of you looks pixelated just for a matter of minutes, and that goes away.
Huh. I'm gonna have to look that up more.
You're too young.
And most of you have training in cornea transplant.
I would say a lot of optometrists are trained in identifying complications from corneal transplants, but ophthalmology and specialists of cornea within ophthalmology, or anterior segment sometimes they're called, would be the people that would help with treatment. So seeing an optometrist might be able to help you to identify if there is something that needs to be treated and get you to the right place. Yeah.
What does it mean when your eye doctor tells you that they cannot bring one eye up to 20/20 with corrective lenses? And why can't they?
Sure. There could be a lot of different reasons. So typically, I mean, what frustrates me is a lot of times you'll hear people who say like, oh, without my glasses, I'm legally blind. And like, I get what they mean by that. But if you can get corrected with glasses to 20/20, that's perfect vision. So sometimes, typically it's usually an eye disease or something wrong with the eye, whether it's the macula, the optic nerve that would impair the photoreceptors, which signal to the brain what you're seeing, as to why you couldn't. So I don't know. It could be a number of different any of the eye conditions we talked about could be causing the vision not to be correctable to 20/20.
Would it be astigmatism?
So astigmatism is usually corrected with glasses. So unless there are times where individuals are born and through development develop a high prescription or a high amount of astigmatism in one eye, and depending on when they start to wear glasses, if that eye isn't developing as quickly because it's not fully corrected, then it may never reach that potential during development. But if it's something that's more acquired, it's usually from an underlying condition. Oh, I think we have one right over here.
I can't see.
I have macular, I have glaucoma,
Okay.
and my mother was blind for 10 years. And I said, what do you see? It's black, or black. And I thought, oh, I don't want to live like that. So I went to the doctor, and he said, I do have glaucoma. And I'm losing my vision in the left eye. But he says, you don't have to be blind. That's what I want you to know the truth. Because he says, you don't have to be blind. If you keep each eye on a single digit tension,
Hmm.
really stable vision, then we are not never going to figure out. I don't know if it is true or not, but it's so simple.
So I will say that if you were to have an eye condition, the one thing about glaucoma is that usually it is controlling the pressure, and that controls the progression. So if someone gets their pressure under control with a good regimen of drops, we typically don't see progression. Or if there is progression, it's so slow that you never actually recognize or have symptoms throughout the course of your life. So I don't think he's wrong. Yeah, that's why. And I mean, I think that's a lot of times doctors will tell you that because they want you to keep coming back, because that's how, glaucoma can be irksome because you have to usually follow up so frequently to get your pressure checked. But the pressure is the one thing that we can control to prevent it from getting worse. Yeah. Yeah. Yes, especially typically you want to keep the pressures in the typically, I mean, normal is different for everyone, but depending on where you start, your pressure at its highest is that oftentimes dictates how much they want to lower it by. But yeah, usually if you can get it down to the low teens or lower, single digits, that's usually the best bet.
Well, we're wanting to respect everybody's time, and Dr. Killen has generously offered to come back again at a later time, and we will take advantage of that.
Is there any other thing you want to talk about right now?
I don't think so. I think that's it.
Okay, I just want to introduce Megan Hayden. Come on up here, Megan. She also has offered to come and talk about what she does, and I'll let her.
Well, I think Dr. Killen, you did a great job.
Thank you.
Listening, so let's just thank
Oh, thank you. Thank you.
I think a lot of what Dr. Killen shared is everything that happens before I would come out and see you. So I'm a certified orientation and mobility specialist. I'm one of those special people that he would probably could refer to come out and work with you in your home. I am also a certified vision rehabilitation therapist. So I do functional low vision evaluations in people's homes. A lot of the devices that he showed you are things that I would bring out and show you. And we would functionally, I don't do it as an eye doctor, I do it out functionally and evaluate you for filters and different lighting evaluations and glare and all the things that he talked about. I kind of filter down to me, and that's what I do as well. So I work with people one-on-one. I come out to your home or to your business or to your school if you're a student on campus, and I work with you to figure out, just like he does, what are your individual goals and how can we help you reach those goals. So just like he was saying, that's exactly what I do, but in your own home. And so I work for an organization called the Sight Center. We are located up in Toledo, Ohio, but I'm the Lone Ranger down here in Central Ohio. I've been doing this for about 18 years. And I travel around in my little car and I bring all of my devices out to people. And I work with you and we determine what your goals are. So that's just a really quick idea of what I do, but an orientation mobility specialist, if you're wondering what in the world that is kind of like a very specialized physical therapist, except I'm working with you on trying to navigate your world. So if you're having a hard time with getting around, maybe you are having a hard time seeing that step, or you missed the curve, or maybe you are having issues with depth perception because both of your eyes aren't working at the same acuity level, right? Maybe you are forgetting the route, or you just wake up and the vision is blurry and you have good days and bad days. I've had patients that can drive in the morning and they're legally blind by the evening and they cannot drive anymore. I've had people that, they get better throughout the day with their vision. So it just changes. So some people actually need a cane in the evening because they have conditions where they're night blind. And so when you cannot see at night, you actually do need a cane. Or you could be driving during the day. It's crazy. It sounds crazy, but that's the kind of thing that I work with all the time. So people that have strokes, like he was mentioning, I work with them as well, trying to navigate their world. So it just depends on what everybody's goal is. And I work with, if you're having a hard time with your microwave, right? If you can't see the numbers on your microwave, or if you're having a hard time, you're afraid of maybe cooking on your stove. You are afraid of knowing what your medicine levels are. How can we organize that? How can we